Well, greetings, everyone, and welcome to another episode of our WCNfluencer podcast. I'm your host, Christopher MacLellan, and I am honored to have one of the founding members of JEM Research, Dr. Mark Goldstein, with us today. Dr. Goldstein, thank you so much for taking the time to visit with us today.
Yeah, my pleasure, Chris. Thanks for having me.
Yeah, we've been looking forward to doing this for quite a while, and today's the day, and here we are. And one of the things that I've been thinking about as preparing to visit with you today is you have such a wonderful and distinguished career, but what led you into the research component side of medicine?
I was in private practice, for many years. And after about 30 years of that, I decided to pivot my career and focus primarily on clinical trials and research. And that's, been a great segue for me, particularly as I got a little bit older and more focused in what I was looking to do. And so clinical trials in particular, as it relates to Alzheimer's disease, became a really good focus for me.
And I think we often lose track, especially as caregivers, when we're in the midst of caring for somebody else, how important these clinical trials are for not only the physicians who are conducting them, but for the thousands upon thousands of people who are going through, especially Alzheimer's and dementia.
Yeah, 100%. And I mean, I say to people every day when they say, Dr. Goldstein, I don't want to do a clinical trial. I don't want to be a guinea pig. One of my favorite, or I should say least favorite, least favorite off ramps. And I say to them, Mrs. Jones, how many medications are you taking? And Mrs. Jones will say, well, I'm on 6 medicines. And I say, well, how do you think those got there, but for people who participated in clinical trials to get them approved? So when we meet with people with a little bit of open discussion, we very often bring them around to the fact that there would be no improvements, no developments, no breakthroughs without those people whom we call medical heroes participating in clinical trials.
It's so important for people to have a clear understanding how much this helps in the study of all diseases. But you really mentioned at the beginning one of the big topics within the caregiving space is Alzheimer's and dementia. And there's also a misnomer about what actually is Alzheimer's and what actually is dementia. Can you help clarify some of that for our viewers?
Sure, that is very common. I don't know if I'd call it a misconception as much as a misappropriation of the term. Dementia, I like to think of as the pie, and Alzheimer's as the biggest slice of the pie. So in other words, dementia is the general term for any condition that causes inability for an individual to manage his or her life properly. So it can involve memory problems, spatial orientation problems, problems with advanced problem solving, word finding, calculations, and so on. And there are many causes of dementia. And again, Alzheimer's disease is the most common cause of that syndrome that we call dementia. So in other words, all Alzheimer's disease is dementia, but not all dementia is Alzheimer's disease.
I think an example that I've learned over the years would relate to like Parkinson's. Parkinson's is a dementia as I understand it, but as a layperson, I would not have thought about that until I had been educated.
Yes, Parkinson's disease can be one of the causes of dementia. Parkinson's disease, as you may know, is a condition unto itself, but often associated with it is a dementia. In other words, aside from the movement disorder of Parkinson's, the shaking, the slowness, the balance difficulties, there can be cognitive impairment as well.
What would you say to a new caregiver that is recognizing something is wrong with their spouse or partner or adult senior parent, that they're noticing some memory loss or some symptoms that just don't seem like the same person that they've known for years? What are some of the key things that people should be looking for?
Sure. Yeah, I mean, in this day and age, I suggest to anybody, whether they are the individual or the caregiver, as you mentioned, the person who cares about the individual,
Mm-hmm.
if you notice changes in memory, in function, in directions, in word finding, any of those things, the question always becomes, and I again say this to our patients very often, is it something or is it nothing? Because
Right.
very often it can be normal aging in people. As we
Mm-hmm.
get older, typically above 60 or 65, it's very common to have some cognitive issues. The
Right.
question becomes, is that the very beginning of something that 2 or 3 or 4 years down the road will clearly be worse, or is that just normal aging? And I would tell you, I would take this opportunity at this moment to say that back in the day, that patient might see a neurologist, and the neurologist had limited tools in his or her toolbox.
Yeah.
So he or she might say, well, I'm not sure. Come back in 6 months. We'll see how you're doing. And if things are worse, then maybe it's something. And if you're doing about the same, I'll see you in another 6 months and we'll see what's going on then. Well, that's changed dramatically in the last perhaps year or so, maybe longer, where we now have what we call biomarkers, which are objective tests that
Mm-hmm.
can tell us whether or not someone with complaints is on the pathway to getting worse from Alzheimer's disease. And those biomarkers currently, practically speaking, take one of two forms, either blood tests or special brain scans called PET scans, both of which can give us a lot of information as to whether even trivial memory complaints are likely to get worse over time or not.
Yeah, as I was listening to you, I was thinking about a toolbox, how much the toolbox has changed over the years that can help physicians like yourself be in tune with what's going on with the patient.
So the key has become, without question, early intervention in people that have problems, which is why I would emphasize to anyone who might be listening or viewing this podcast that ignoring symptoms, in my opinion, is not advisable. And the
Right.
reason is because we can make definitive diagnoses earlier and earlier, and there are options for treatment that did not exist as recently as 3 or 4 years ago. So, to your listening/viewing audience, I would again emphasize, don't ignore symptoms. The analogy I often use is, if somebody feels a lump somewhere,
Mm-hmm.
is the best strategy to say, well, it's a lump.
It'll go
I'm going to
away.
go to the movies. It'll go away.
Yeah.
Or do you
Mm-hmm.
want to get it looked at? Well, now I think we are at a point where it really behooves people to seek out answers when they have cognitive complaints and try and figure out, again, is it something or is it nothing? Because if it is something, there are options to do things about it. And those options are clinical trials, but there
Mm-hmm.
are also commercial treatments that are available, and people might, in after, of course, conferring with their personal physicians and hopefully neurologists, decide to go in that direction.
Because it's so much, I don't know, better or easier, what the right word would be, to be proactive instead of reactive in any type of health situation.
Yeah, I don't know about easier, Chris. I do know it's advisable.
That is the right word.
A lot of times people put their heads in the sand, and that's not the right way to go.
What are some of the current treatments that you're seeing now with Alzheimer's?
So, as we speak, there are two approved treatments, therapies. One is a Eisai pharmaceutical drug. The medical name is lecanemab. The generic name is Leqembi. The
Mm-hmm.
other drug is an Eli Lilly medication, medical name donanemab. It goes by Kisunla. They are both given as IV infusions. One of them, the first one I mentioned, every 2 weeks. The second one every 4 weeks. They have been proven to slow down worsening. I emphasize they're not cures.
There's no cure, yes. Mm-hmm.
They do not improve cognition, but they may slow progression
Yeah.
for a period of time. They both have certain recognized side effects, specifically small areas of swelling or bleeding in the brain, very often without causing any symptoms, although sometimes it can cause symptoms,
Right.
and they require frequent safety monitoring with MRI scans,
Right.
typically anywhere between 5 to 7 scans in the first 12 months or so.
Right.
So, you have to be carefully monitored by physicians who know what they're doing with those drugs. They are a good first step, but they,
Mm-hmm.
I emphasize, are not miracle drugs, which is why there are currently dozens and dozens of clinical trials that are still being done for treatment for Alzheimer's disease. If those were miracle cures, I'm pretty sure the industry would dry up
We're dry.
for
Yeah.
ongoing clinical trials.
Yeah. One of the questions I get asked quite a bit, and my caregiving experience did not interact with dementia and Alzheimer's, but we've had family members, uh, in my personal life, and I've often wondered, is it a hereditary disease?
So there is an hereditary predilection, a propensity to develop it if you carry certain genes.
Mm-hmm.
Um, Certain genes, which are relatively rare, guarantee you will develop the disease. Um, there was a wonderful movie a few years ago, Still Alice,
Oh
uh,
yes, yeah.
a wonderful movie, very sad, about a hereditary condition. And it involved whether even her children would choose to get tested or not. But that's not as common as garden variety, if you will,
Mm-hmm.
Alzheimer's disease, in which there is a gene that if you carry two doses of it, one from your mother, one from your father, it's called the ApoE4 gene, you're much more likely to develop the disease. But even if you do carry two doses of the gene, you're still not guaranteed to get the condition. It's not, I always tell patients, like brown eyes or blonde hair.
Right.
It's not quite as stark a relationship. But to your question, there is a hereditary tendency. So if you have a first degree relative who had the disease, a mother, a father, an older sibling, you are more likely to get it, but it doesn't mean by any means that you
As
will.
amenable. Right. Yeah. Goodness, what a great conversation. It's so informative and just very relaxed. But I also know that the work that you do at JEM Research, it's broader than just Alzheimer's and dementia. Can you talk about some of the other studies that you focus on for our viewers?
Sure. We also do studies to slow down the progression of Parkinson's disease. That's a condition for which there's no approved medication to do that. For Parkinson's disease, which in and of itself is a somewhat unfortunate condition, particularly in younger people, um, there are many medications that can help with the symptoms, the movement disorder, the tremor, other situations that those unfortunate people have, but there is no approved medicine that can slow down the progression. So we have clinical trials for that. Um, and we in the past have had trials for multiple sclerosis, seizures, Lewy body dementia, which is another
That's a whole
uh,
other.
whole
We could do
other.
a whole podcast on Lewy body dementia.
You know where to find me,
Yeah.
but but yeah, that's a different condition. But again, one for which there's no proven treatment to slow it down. Um, but our main focus in the neuro world at this moment is Alzheimer's disease.
I don't mean to put you on the spot when I ask this question. With your vast experience, do you foresee a cure for Alzheimer's and dementia?
I do, and in one of two ways, I would say. Um, in addition to doing clinical trials for people who have overtly manifest disease at this time, we have trials for people that are at high risk without
Hmm.
symptoms. And that's where I believe ultimately big inroads will be made, treating people even before they clinically develop the disease. So we have trials looking at those people. We can identify high risk individuals and offer them treatment options. So that's one way I think great inroads will be made in preventing or curing the disease. The other way I believe it will be made is in combination therapies. Currently, the two drugs that I mentioned that are approved direct their therapeutic uh, focus at ridding the brain of a protein called amyloid, which accumulates in the brains of patients who have Alzheimer's disease. You cannot have Alzheimer's disease without brain amyloid. But that's not the whole answer. There are a lot of other things that go on in the brains of people with Alzheimer's disease. In addition to amyloid, they accumulate another toxic protein called tau, TAU for your listening audience that might want to look that up. There's inflammation that goes on, many other things. And so I believe ultimately combination therapies will be utilized that may even be individualized based on the particular makeup of a given patient's condition.
Hmm.
A lot of amyloid, a little bit of tau, a lot of inflammation, he or she gets this cocktail. A little bit of amyloid, a lot of tau, not so much inflammation, he or she may get this cocktail. I liken it to the way we treat cancer, where
Uh,
we can direct therapies based on many different parameters that the patient with cancer might have.
Dr. Goldstein, this has just been terrific. But let all of our viewers and listeners know how they can learn more about GEM Research and get involved in some of these studies.
Well, we would love to see any of your listeners or viewers. We do routine evaluations in which people are seen by neurologists, myself, and Dr. Linda Powell, who is a board certified neurologist, and we will see people, we will assess them. They may be candidates for clinical trials. They may have nothing wrong with
Mhm.
them. We may suggest other avenues. Um, and many of these people can be tested for whether or not they're at risk, typically above the age of 50. I should emphasize that. We wouldn't want to be seeing 22-year-olds worried about their
Right.
memories, but people over 50, we can generally see at JEM Research, and are happy to do so. And, I will make a shameless plug here, which is that there are never any costs involved in anything we do.
That's not a shameless plug. I was going to kind of tweak you into that because I actually, the way we have all met is I came in for a clinical trial on one of the Alzheimer studies because we have it in our family, and I was concerned
Right.
myself, and I wanted to be proactive instead of reactive, and the process was easy, professional, and there's a lot of great people there on staff. So it's really my honor to be able to participate not only in the study and have the testing, but to have you on as a guest to help so many people that or watch our podcast and listen to our podcast and let them hear from the source how important this is.
Sure. I appreciate those words. Yeah, so we are happy to see people. There's no cost, there's no insurance involved. We don't care about any of that. And most importantly, everything we do here is private. And that's important to people in this day and
Very
age
important.
where
Right.
things get out and you worry about that. But we're very careful about the sanctity of medical privacy.
Very good. And we'll have all of the contact information for JEM Research in our show notes. And Dr. Goldstein, I have a feeling this isn't going to be the only podcast we do with you and other staff members on JEM Research. Thanks so much for joining me today.
My pleasure. Thanks for having me.